Okay. All right. So most of you guys know me. So I did medical school at UC Davis, did a PEDS residency, and then a PEDS fellowship at Children's Colorado. Our team, you guys may not necessarily know as well. We've had a lot of new additions over the last few years. But basically, in a nutshell, sports medicine, TBI, concussion, that's a lot of the focus today. We do comprehensive concussion care, and a lot of what I'm going to be talking about today is the complex pediatric concussion patient. So we will dive into that. This is our pediatric sports medicine team. We've grown. We have now 6 ped sports medicine docs on our staff, a couple athletic trainers. We also have our comprehensive concussion team. And so we have a mix of multidisciplinary folks here, including NPs, PAs. We also have Dr. Pollack, who consults with our patients, Kent Baker, who's a therapist, and then, of course, our athletic trainers that help with our patients. Housekeeping items, the restrooms are basically right out that door if anybody needs them. We have food, CME, CEU, and those of you guys that registered, there should be a survey that comes to you directly to your email. If you haven't registered that way, just make sure you have your name and email on the sign-in sheet. And specifically for BOC, Leanne Boone, who's here, who put together the CEUs. Thank you, Leanne, again for that. She's got her own check-in as well. So, but Leanne, we will have all those emails for you anyway. So, and if you guys want these slides, we can get them up on our website for you. So no problem with that either. And this should be recorded. So if anyone wants to go back or share this, we'll have it on the registration, the TMC registration site that you went on as a recording. So quickly, the outline, the roadmap of where we're going tonight. We'll start with some case reviews. And those of you guys that have seen my talks before, you'll probably recognize some of it. They're real patients I've had, and then we'll start to talk about complex concussions. We'll define it. We'll talk about concussion profiles or subtyping, a very important concept that can be used for all concussions, but it's particularly important, in my opinion, for complex concussions because targeting management becomes so key. We'll look at the consensus summaries in terms of the evidence, and then we'll talk about management and the comprehensive care model for the complex concussion. Okay, so case one, this was an 11-year-old high-level gymnast who had a minor MVA or motor vehicle accident, no loss of consciousness, complained of being in a bit of a fog, some dizziness, some headache, assessed by the school nurse the next day, and returned to class saying, I'm fine. A relatively stoic kid. Continued with school activities over the next 1 or 2 weeks as usual. So all the regular demands of school and exercise and activity. Completed tests, computer projects, continued with her gymnastics. And there was lots of note-taking involved as well. 2 weeks later is when I heard about this patient for the first time. She was hospitalized with a severe headache, gait disturbance, difficulty with speech. She was essentially becoming aphasic, couldn't get words out. So her primary was very worried, and appropriately, they hospitalized her, make sure she didn't have a stroke or something weird. They did MRIs of the brain, the spine, did an EEG to make sure she wasn't having seizures, all of which were normal. And she was discharged relatively quickly from the hospital with a diagnosis of concussion 2 days later, and ultimately referred to our clinic for follow-up. When we evaluated her, this was at clinic at 1 month. Her cognitive testing at that point still showed severe memory and processing deficits. Vestibular testing showed poor postural control and balance. And her vision testing also showed abnormalities with smooth pursuits, saccadic movements. Those of you familiar with the King Divot test, her total time was over 75 seconds. So more than about 25 seconds per card. I'll go over those a little bit later. And then convergence, near point convergence was 14 centimeters. And that is pretty significantly abnormal for those of you not familiar with that. So the question is, what next? Where do we go from here? So here's another case. This was another teenager that I saw a few years ago, 13-year-old healthy boy, got elbowed in the head in basketball, no loss of consciousness, some headache and dizziness, assessed, had no red flags. So in other words, didn't need to go to the ER to get a CT scan based on the assessment. No focal neurologic deficits, et cetera, et cetera. Continued with regular school activities, complained of ongoing worsening headache and new migraines. So at 4 weeks, saw a neurologist, started on Topamax, had a normal MRI brain, symptoms continue to progress, no longer tolerating sports or even exercise at this point in an athlete, struggling with academics and with his grades. He used to be a very high achieving 4.0 student, now failing out of a couple of classes, feeling depressed and hopeless. And at this point, no academic accommodations, so really no support with what was going on in school. At 3 months is when we saw this patient in our clinic for the first time and sort of put together the story, and still had ongoing severe cognitive deficit, vestibular ocular deficits, exercise intolerance, and cervical dysfunction with migraines. And again, so where do we go from here? So these are our complex cases, right? So when we talk about complex concussions, there's a few factors that play into it, and we'll define that on the next slide. But in a nutshell, these are folks that have surpassed that 1 month mark, and they're clearly not getting better. So what is a complex concussion? So basically, we're talking about a mild traumatic brain injury with persistent post-concussive symptoms, or PPCS. We'll use that term a lot the rest of the talk, that are there for greater than a month. And that's as defined by CDC, WHO, AMSSM, fifth consensus. So there's a pretty good consensus on that definition. For it to be a concussion, obviously there has to be trauma. So this is caused by direct or indirect traumatic forces to the brain. So whiplash mechanisms, other types of translated forces that cause rotational effects to the brain, which obviously sits in fluid inside the skull, all can potentially create brain injury. Okay, it doesn't have to be blunt trauma to the head. One or more clinical signs and symptoms, obviously, though, that has to be there. And then by definition, mild traumatic brain injury, GCS, is going to be 13, 14, or 15, 15 being normal. So there might be a little bit of confusion or disorientation, but these are not patients that can't open their eyes to command, that can't move, that don't respond to being pinched in terms of pain localization. Those would all be much more lower GCS scores and more severe, either moderate or severe traumatic brain injury. So we're talking in the context of mild traumatic brain injury, those that meet the chronicity, that have symptoms that persist for greater than a month, will now fall into this category of persistent post-concussive symptoms. And we see this in the pediatric groups, and we see this in adults as well. There are other complex concussions. So complex is just kind of a generalized term that we use. But if someone, for example, even if they're at week 1, but their brain injury involves a skull fracture, a bleed, some other structural lesion on CT scan or MRI, those are complicating factors. So we would still refer to those as complex concussions. Those are much more rare, obviously. By far, the most common complex concussions we see are those with persistent post-concussive symptoms. So real quickly, separating the simple concussion and the complex concussion. I think it's important to review the simple concussion, because really 80% of the mild traumatic brain injuries, 80% of the concussions are on this side, right? And so by far, this is the more common one. They get better under 4 weeks, and that's the expectation. Generally, their symptom clusters are in the physical realm. And that's not to say they don't have cognitive, mood, etc., but predominantly these folks present with headache, vestibular ocular motor deficits, cervical. And basically the management for simple concussions, when we talk about concussion protocol, or people throw that term out there, they're basically talking about the management is, we have a lot of evidence-based research on how to manage simple, straightforward concussions, right? And there's a lot of data that it's critical from the beginning to get these guys removed from play. The longer they stay in, the longer they take to recover. Early intervention and early evaluation is key. So we recognize that those who are evaluated by healthcare professionals early end up doing better. And those who actually have a concussion, that we have early intervention, so return to learn, return to play, but also early rehab based on their needs, whether it's vestibular, cervical, etc., and certainly active rehab, which is exertional rehab. Those are all key pieces to improve recovery. And they're all key elements to the simple concussion as well. And ultimately, if we implement these things properly, we expect them to be better in a few weeks. And most of the time, these folks are going to return to back to all their normal activities, okay? Whatever their sport was, even if it was high risk. Complex concussions is kind of a different beast, right? And it starts with the fact that these symptoms are persisting for longer than 4 weeks. And now we're talking about folks at 4 weeks with significant symptom burden. If they're almost better, then, they're a week away from full recovery, then, it's kind of like, and they're in that gray area, and really they're more like simple than complex. But we know there's a lot of patients that even in that 4 to 6 week time frame are struggling tremendously. Those 2 cases I just presented are examples. And at that point, you don't really have an expected recovery timeline. You can't see them and say, okay, well, we're going to do these things and in 2 weeks, you'll be better. You really don't know. And as you start to implement treatment and dig deeper in your evaluation, then you start to maybe figure out if there's a trajectory to their recovery. But in the beginning, you really don't know. And with post-concussive syndrome, what we've seen in the research, although the research is sparse, is that there are multiple stages of recovery. And so really it's a mixed bag. Some people are better in a few months and others take over a year. So we really don't try to look in our crystal ball and tell them when they're going to get better. Instead, we really try to evaluate what's going on, establish a more complex workup and evaluation that I'll get into, and then really look at multidisciplinary targeted treatments. And this is where profiling or understanding the subtype, as we say, of the concussion can be very important. The clusters that we see more of in the complex is cognitive, visual, and mood, okay? Again, that's not to say that can't happen with a simple concussion starting in day 1. And a lot of them do have those factors, but these are the predominant cluster symptoms that we see, or the predominant profiles when you're just looking at data in this group. I'll show you some studies looking at that. And then medications, generally speaking, medications are not FDA approved for concussions, and we try not to use them. But with complex cases, sometimes you need to treat sleep, sometimes you need to treat migraine. So there are definitely more scenarios here with prolonged symptoms that you might consider using medications. All right, so these are a number of papers that are pretty recent in the last couple of years looking at prolonged symptoms. So we're finally starting to get good data, more long-term data like the TRACK study, which follows patients all the way out to 1 year, and recognizing that mild traumatic brain injury can in some cases result in symptoms 3 months out, 6 months out, over a year out. And I think that's important, starting there and then starting to really figure out what are the patterns we see. This is a study we did a few years ago looking at 150 patients with prolonged symptoms out of our center here. And basically what we were trying to figure out is what stage are most of these guys at. And what we found is stage 1, which we defined as under 3 months, was still most of them, 31%. So if you've got someone with PPCS at week 4, it doesn't mean they're going to need to take a year. Still we're going to see the majority fall into this group, but a pretty good chunk also in the 3 to 6 month group, which is stage 2, and then also a significant chunk in that 6 to 12 month range as well, which is stage 3, and only about 10% or so with symptoms over a year. This is all comers with prolonged symptoms. So what about symptom clusters? So the idea of profiling or clustering symptoms, subtyping, phenotyping, whatever you want to call it, really started with UPMC. And they use the term profiles, and I think that's perfectly fine. And so back in 2014, 15, these guys have been national leads on a lot of the concussion research. And Mickey Collins and his team up there started to identify these different symptom clusters that fall into these different profiles that are commonly seen amongst concussions and those with prolonged symptoms. And what they found is if we can hone in on these different profiles or symptom clusters, then we can target management better. So the idea being that a concussion isn't a concussion is a concussion. They're not all the same. We all know that, right? In theory. But this gives us a way, a paradigm to really be able to break down what type of concussion we're talking about. And then from there, it can guide our treatment. So since that time, a number of different papers have come out from multiple institutions across the country looking at subtyping, including multiple different validated screens that have come out to be able to do this. So over time, we've added a few different profiles to the mix, like sleep, exercise intolerance. This was a recent study that this was an abstract that we just presented at AMSSM this April. And the idea here was to look at cochlear dysfunction. A lot of our patients with persistent post-concussive symptoms complained of a lot of sound sensitivity and difficulty filtering out noises and even ear ringing. So those 3 questions became our key questions that we asked every patient when we took them through the validated screen. And over, in this case, you can see over about 100 patients, we wanted to see what was the likelihood of patients endorsing cochlear symptoms. And in other words, sort of endorsing that profile as well. And what we saw was that 85% of patients at least had some form of cochlear symptoms. So it's very common and really shouldn't be neglected as a profile. Let me go back here. So yeah, and then I'll just show you, it's very common, but only in about 20% was it in the top 3 profiles. So it's usually not considered a severe or or their most serious problem, but it is very common. Most 85% were endorsing it. So if we come back here at these profiles proposed originally by UPMC, these are a couple of the other areas, the cochlear or the auditory system and the autonomic system, which sort of falls under exercise intolerance, that are probably other ones that as we move forward in the next few years, we'll start to see more and more research on, and they'll probably be part of the established profiles that already exist. This is the screen that we use. It's just came out in 2020, also out of UPMC. And the idea of the CP screen was to ask a few more questions than, for example, the SCAT-5, to be able to then break down questions per profile and provide us with a weighted score of each profile, so that when we get this validated screen completed, we can look and pretty quickly get a sense of if someone's ranking cognitive fatigue or visual or whatever really high and something else really low. And that helps guide us right off the bat. This is obviously subjective. It's coming from the patient, but I think it's still very important. And then what you do is you see if your objective tests and data sort of match up with what they're telling you. So what we have seen in terms of our pediatric patients with post-concussive syndrome or complex concussions with prolonged symptoms is that the mood, the cognitive, and the visual profiles tend to rank high in this pediatric group in particular. This is what we saw. We presented this at PRISM, Pediatric Research in Sports Medicine, in this January. And basically what you can see is cognitive fatigue by a good distance took the #1 profile on average, followed by visual and mood, which were pretty close. So these are definitely 3 profiles we want to be thinking about in a complex concussion. They're very common. If they didn't rear their head initially, they're usually going to rear their head at this point. Mood is a great example. But again, that's not to say that someone with an acute concussion that just happened yesterday isn't going to have these problems. That can happen as well. So, all right, so management. So we'll shift gears here a little bit. We've talked about the definition. We've talked about how to sort of subcategorize these complex concussions or subtype them. So now we're going to talk about how to treat them. So these are some of the general concepts, right? We want to use evidence-based approach. We want to look at profiling to guide us in subtyping. And that's ultimately going to guide a multidisciplinary targeted treatment plan. We have a lot of different options in terms of different types of therapies that we didn't have 10 years ago. So things have really changed in terms of the services we can provide for these kids and these folks that have prolonged symptoms. We'll get into that. And then ultimately recognizing what the predominant profiles are and what the refractory profiles are could be key to recovery, right? So predominant is obviously the one that they're endorsing the most. Refractory is kind of a little bit of a newer concept, the idea being that it's, let's say sleep, for example. It's there, the kid says, I'm sleeping 3-4 hours a night. You keep working with the kid, sleep hygiene, this, that. They keep coming back and saying, yeah, I'm still sleeping 3-4 hours a night, okay? So you're trying to treat it, even if you use meds, whatever, but for some reason it's not responsive. And that's a refractory profile that can certainly be the reason you're being held back in terms of trying to get to recovery, and you really need to address that. So, doing okay, Eva? Okay, all right, that's okay. It's this part is not very visual. Hopefully, you can get that off the screen there. But anyway, so these are just let's see if I can. These are a couple of the consensus statements here. CDC, fifth consensus, AMSSM, all in the last 5 years or so. You want me to give you a minute, Eva? Okay, yeah, go ahead. Well, take our little break here. Okay, thank you. So, okay, so again, here are some of the consensus statements, and we're going to try to summarize these, okay? So it starts with preventing PPCS, right? Early intervention, we kind of talked about this with the acute concussions. Everything you guys are doing on the front lines with these acute concussions matters, because PPCS isn't just something that's going to happen or not happen. Oftentimes it happens because the management early was not what it needed to be. So, and it starts with the acute phase. So we, in the fourth consensus and some of the older data, we used to consider the first couple of weeks the acute phase, and we used to do things like not exercise the first couple of weeks, etc. Early on, there was even complete cognitive rest. People would be out of school. So all that's by the wayside now, right? First 24 to 48 hours, again, generally speaking, is the acute phase, and we really need to get on our horse after that, right? And everyone's different. Some people are able to do a lot early, and others can only do a little bit, and you can adjust to them. These are case by case. But the idea is that early intervention is definitely superior to absolute rest in terms of time to recovery and preventing the morbidity that comes with prolonged symptoms, okay? And what does this generally involve? Early intervention involves active rehab, which is subsymptom threshold exertion. We'll talk more about that. Vestibular and cervical exercises can be key. Return to learn is key. And obviously things like trigger avoidance, especially screens, which we've seen again and again can be a big problem early on if we're overusing them, especially in the world we live in now. So if we can get on top of early intervention with the acute concussions, we can prevent and not only reduce recovery time, but decrease the morbidity related to PPCS and have better outcomes, okay? Here's some of the other summaries from the consensus statements. Avoiding routine CTs. This is a functional problem, right? So you might need a CT up front if you're worried about a bleed. You might need an MRI down the road if they're taking too long to recover. But ultimately, this is a multidisciplinary issue that involves functional testing and a functional approach, because their neurologic problems are mostly functional. And concussion by definition is a functional problem. We want to use validated tools like the SCAT5, the CP screen, the vestibular motor screen, computerized cognitive testing like Impact. We want to avoid absolute rest, whether we're talking cognitive or whether we're talking physical, for more than a couple of days. And rehabilitation over meds, right? So we really want to be getting people moving, exercise, rehab, and then recognizing that 20 to 30% may develop prolonged symptoms. And so if they're hitting that 4 to 6 week mark, it's time to refer them. And sometimes there's risk factors for prolonged symptoms that we can identify. We'll talk more about that later. Okay, so what about the multidisciplinary approach to the complex concussion, the persistent post-concussion? So again, starting with subtyping, and that subtyping will allow us to individualize their plan. Active rehab is still critical in this group. Almost everyone in this group has some level of exercise intolerance. Okay, it's very rare that they show up at 2 months saying, I feel awful, but I'm out there, full blast on the soccer field. So we really need to get, and a lot of them aren't exercising at all. And so we need to get the exertional rehab protocol moving with these guys. There is, more of a workup here at this point. They're prolonged, they're not better. We need to make sure that there isn't other reasons for that. So this is kind of in the window where we might consider an MRI. We might obtain some blood tests to look at the pituitary function. Neuropsychiatric testing may be considered if there's a lot of cognitive problems, et cetera, et cetera. And then ultimately, we want to have a targeted approach to therapy. It might involve speech, OT, PT, vision therapy. It all depends. And if you're subtyping these patients and you know where the profiles, the predominant profiles are and profiles of greatest resistance, then you know where to really target their treatments. So you don't do everything at once. And ultimately, these two pieces are key to always look at and address if there's problems with the mood and sleep profiles, because they're going to get in your way. Okay, no matter how much you work on cognitive rehab, if your kid's still sleeping 4 hours a night, they're going to struggle. They're not going to get better. So we have to address those issues. They're often referred to as modifiers because they can really affect the other profiles significantly. So we see that a lot and implement cognitive behavioral therapy and things like that for sleep disturbance. So, all right, let's take a few minutes to talk about exercise intolerance. So I apologize too much for those of you guys that aren't into this as much as I am, but I think it's important. And it's the first one of the profiles I want to get into. So basically, the idea here is after 1 to 2 days, if it's tolerated, so it needs to be sub-symptom threshold exertion. That means it cannot worsen their symptoms. And it should be monitored. And really, we should do some testing to really establish what the right exertional step is. And that includes the intensity. So the heart rate or rate of perceived exertion, the modality, the type of exertion we're doing. Some patients can handle being on a treadmill and running and others can't. They need to be on a recumbent bike. We have to figure that out. And then the duration, obviously, we want to start with a relatively light duration, 10 to 20 minutes, and build on that. So the last decade or so, really the last 15 years, we've had a lot of great evidence coming out on active rehab and exertional rehab protocols from multiple different institutions, which has led to articles like this in the New York Times, basically saying, and this was back in 2017, by the way, new guidelines suggesting that most young athletes should be encouraged to start being physically active within a day or two of the injury. So, and it turns out that this is really the case, young athlete or not, right? We're all human beings that are meant to be active and meant to be physically active, and exercise is good for all of our bodies and all of our brains. So, I don't care if you're an athlete or not. We're going to implement the active rehab protocol, but we're just going to cater it to where you're at, right? Athletes may be able to do more initially. So whatever it is, we have to cater to that patient. So again, just some more support coming out of these consensus statements, more or less saying the same thing. Here's the CDC saying one of the most important messages of the guideline is to get things going in the first days after the injury. Here's the AMSSM statement basically saying the same thing. After a brief period, 24 to 48 hours of cognitive and physical rest, we need to get moving on rehab. And then these are a number of studies, original research articles that came out of University of Buffalo and John Letty's group. And these are all basically the studies that I was sort of alluding to really over the last 10, 15 years in support of active rehab protocol. This right here, which was in 2019 in JAMA, was the first randomized clinical trial. So we had a lot of cohort studies showing that, hey, this is helping this group get better. Exercise is helping this group get better. But this is the gold standard, right? The randomized clinical trial. And this was done in teenagers. They took one group and they basically did the active rehab protocol. They took another group and used the placebo, light stretches as a placebo. And what they found is significantly faster time to recovery in the group that utilized exertion, okay? So what does active rehab protocols look like? So there's multiple protocols out there. The Buffalo protocol out of University of Buffalo is the most commonly known, probably. They utilize the Buffalo concussion treadmill test and bike test to really determine the exertional dose that a particular patient has. It's hard, especially with complex concussions. You got to remember, complex concussions, these patients have struggled with trying to exercise probably for a while, right? And they get headaches and dizzy and light. Maybe they fainted. So it's hard to just tell them go exercise. That's not it, right? We have to figure out where they're at. And we got to figure out their appropriate dose. If you overdose, they're going to have problems. If you underdose, they're not going to get better as fast. So you got to get the right dose. And the way we do that is we utilize testing. And ultimately, we tend to put these guys in one of these 5 steps. We use a 5-step active rehab protocol, which basically goes from light to moderate to vigorous to maximal with multidirectional movements. And generally, particularly our young pediatric folks, young athletes and stuff, they fall into one of these steps, and then we build from there. So, and this is kind of what it might look like. So someone comes in early. Let's say, the case, I showed you that these folks are struggling with just balancing. Well, I'm not going to run them, right? We're going to put them on a recumbent bike for 10 minutes every day and say, hey, you haven't been doing anything. Let's get some exercise going. We're going to do this consistently. And we're going to start to give our brain an exertional dose that's therapeutic. From there, they may be able to bump up to a seated bike, an elliptical, eventually to a treadmill, maybe walking with incline, eventually running. And this is what step 5 would look like, right? High intensity intervals, functional movements, multi-directional, et cetera, et cetera. And as they progress here, they're not only progressing the modality or the function of exercise, they're also progressing their intensities. They're also progressing their durations, and ultimately moving from someone who's not exercising at all to someone who's exercising like an athlete. So those are pretty big pieces. Any risks or side effects to this? Really, all the studies that we've seen, and there's been a lot, have shown really little to no adverse risks if it's done right. So, and I'd say the main risk is exacerbating or worsening symptoms. Okay, it's not the end of the world, but certainly if folks are pushing through that threshold, athletes might be eager, they may not tell you. So if you're just following symptoms, you may not get the information you need that they're doing too much. And then, you're going to give them, even if you give them the strict protocol parameters for what their dose is, if they don't follow it and they do too much, then that's a problem. And then we have, like I said, athletes or just kids, teenagers that are highly symptomatic when we see them. Their VOMS is terribly off. That's their balance and vision and all that. That's pretty important in exercise. And they just may not be ready to do a whole lot, right? Because they could even be a syncope risk, a fall risk. But that's where, even in that case, you got that recumbent bike. There's a way to get these guys moving, and that's the only way they're going to sort of bust through that threshold, right? They got to do something. So, and then exertional dysautonomia is also potentially could be a big barrier for these folks. It's not as common. But I'll show you, we had a study where we saw it in about 30% of our exercise intolerant folks. So it's common enough, and you need to be thinking about it as a reason for exercise intolerance. And here it is. So basically, folks with exercise intolerance, they generally are going to tell you, I get headache, dizzy, I faint, particularly when I try to get my heart rate up, maybe I get nauseous, but these are the common symptoms they'll endorse. Fatigue, shortness of breath, feeling out of shape, that could be deconditioning. So you kind of got to figure that out. It could still be true exercise intolerance, but we got to figure that out in that case. What are the underlying causes? So the post-concussive causes that we're worried about that often are underlying EI or exercise intolerance are vestibular dysfunction, visual dysfunction, and autonomic dysfunction. Again, it could be related to deconditioning, especially if they've been not doing anything for 3 months. It could be psychogenic, it could be burnout. So those are all things to consider in your differential of exercise intolerance. And then exertional dysautonomia. So it's a big, for folks that aren't used to this word, my patients, when I tell them, they make a funny face, and then they pretty much always ask me to explain it because they're like, what does that mean? So, so I've gotten, used to explaining autonomic dysfunction. But basically, in a nutshell, the autonomic nervous system is going to control heart rate and blood pressure responses to exercise. And it's abnormal when the autonomic nervous system isn't working well because you have exertional dysautonomia. And ultimately, what that results in is instability of cerebral blood flow, CBF, and manifests with the symptoms we see. So some of the things objectively that we can see as we're testing folks, and these are a lot of the things we do here, cardiovagal, autonomic tests, looking at orthostatics, looking at heart rate variability, pupillary reflex speeds can tell you about autonomic function. And then sweat and heat testing is a little bit more sophisticated, and you would need to probably be at an autonomic center like the Mayo Clinic or something to do those kinds of tests. So typically not needed in a concussion patient with some dysautonomia, but sometimes we need to do that referral. So a few papers. These are, again, number of them, John Letty and his group, who has worked very hard in not only the active rehab protocol, but understanding exercise intolerance and dysautonomia. This was from one of his papers, and I thought this was great because they exhibited that folks in particular during exercise tolerance testing that exhibited early symptom onset of exacerbation. So just heart rates under 120 or 130, which is relatively mild for the teenage age group in terms of intensity. These folks were having problems and symptoms, and this usually was tied to autonomic dysfunction. Whereas those who didn't have any early symptom exacerbation, but had more late symptom exacerbation, tended to be more vestibular problems or cervical spine dysfunction, which can also be one of the causes of exercise intolerance. This was a study that we submitted a few years back. Tyler Marks, who's on this, is actually here. So, but we were looking at etiologies of exercise intolerance just in our group. So we looked at pretty good size. We had 342 trials of exertional testing in 120 patients or so. And we kind of just wanted to see, okay, well, what's the testing look like? So, and what are the reasons for exercise intolerance? So 34% of those we tested had exhibited exercise intolerance, okay? And really autonomic dysfunction was about 30%. So that's, it's a pretty significant number. We also saw vestibular in a good amount as well. So how do we manage dysautonomia? Well, so autonomic rehab is a thing, and we've got actually several good physical therapists in town, several that I'm working with over at TMC, for example, that this is an area that they like to focus on, working on autonomic rehab with these patients. In a nutshell, it involves subthreshold exertion. The Levine protocol is very similar to the active rehab protocol. The big difference is if there's POTS or postural dysautonomia, they try to keep them flat. So they keep them on the recumbent bike much more often for the entire duration of the exertional rehab. But also working with postural positional exercises is pretty key with these guys. Hydration, salt becomes pretty critical. Some of these guys need to be on salt tabs and really double their RDA for salt. And then in some of the more severe cases, where they're being seen by autonomic physicians, I rarely prescribe, but there are a couple of medications that can help dysautonomia as well, beta blockers or Florinef. So these are different ways that we try to manage patients who have this problem. All right, so shifting to cognitive impairment or cognitive fatigue, all right? And those two things can be, so, for example, someone can have cognitive deficits and have difficulty just cognitively, period. Somebody else can have more cognitive fatigue where their proficiency is pretty good for, say a couple of hours, but they really hit a wall before, say, the end of school or whatever. So, those two things, although they overlap, they're not necessarily the same. But getting into cognitive impairment, these are some of the ways we assess cognition. The computerized cognitive testing has really given us a quick and easy screen for cognitive testing. Impact came out about 20 years ago now, a nice validated test. There's others. We utilize Cambridge Brain Sciences because we like it, and it gives us good customized composites that we can look at based on the patient's needs. But bottom line, these guys are going to look at memory, processing, attention, reaction time. And a lot of our athletes, we have the luxury of having a baseline test because our athletic trainers get that for us. But many of the non-athletes, you don't have that. So you have to use normative data as far as your comparison. And it just makes it harder. Formal neuropsychiatric testing is a very, very comprehensive way to look at cognition and neurocognitive abilities. This is like a 6-8 hour ordeal. The referral is generally a month or two away from when you put it out at best. So this is not something you can get done right away, like computerized cognitive testing. And then Evoked potentials is also another really useful tool in the complex concussion that can assess more or less the big thing is cognitive capacity and cognitive resources. So it's a neurophysiologic test. I'll tell you a little bit about it shortly, that can essentially look at how well the brain is firing and whether their P300s are suggestive of reduced cognitive capacity or not. Oops. Okay, so computerized cognitive testing. These are some of its uses. It can tell you about the degree and type of cognitive impairment. You can target accommodations based on what you're seeing. If you have a baseline, you can utilize that, of course. If you don't, you still have normative data. Sports clearance tool. So a lot of our concussions that we are trying to clear, we're going to use this to make sure cognitively they are back to their baseline or at least within normative data. And then also, if you've got persistent or severe cognitive deficits, like some of the cases I was showing you earlier, it could be a reason to initiate formal neuropsychiatric testing. So, individualized cognitive action plans are very important. We try to get these out right away. There's a lot of different versions of this, but basically, in a nutshell, the idea is to help folks with return to learn and work. And taking into consideration their cognitive tolerance or fatigue. So they may need shortened days, cognitive deficits. So if they're struggling with their verbal memory, they may need visual aids to help them with that. What cognitive accommodations or modifications might they need? They might need extra time for a test, et cetera. They might need a reader if they're having a hard time with notes and reading things. Ultimately, you're going to want to include in your cognitive action plan critical visual, vestibular, and exertional accommodations too, because usually at school or work, all of that's necessary. So, sorry about that, went backwards. So this was an article, and I think Becky, who's here tonight, Becky or Jenny probably sent this to me again. I don't know, 5 years ago now when we started working on return to learn for TUSD. But basically this article was a nice one, just highlighting that for years we had been focused on return to play. For years, we understood that when there was a concussion, we couldn't just put them back out there, that we had to sort of go through a process to get them ready to be able to return to their sport. But we never did that for the classroom. And that was kind of a neglected area where folks just had to get by and figure it out. Despite their visual or cognitive symptoms. So it was nice to be able to focus on this. And I've seen in the last 5 years, just a tremendous movement in terms of the return to learn throughout districts and schools, which has been great. This is a sort of a basic algorithm that we follow. Many districts here in Tucson follow, looking at these color zones. In a nutshell, sort of going from red, which is when you're at home, taking a day or two off, doing light cognitive things at home, to sort of part-time at school, the orange zone, half-time to full-time, which is usually where the yellow zone is, still with some partial accommodations. Green, you're full-time, transitioning back to full workload, and by blue, you've been cleared for full academics and then sports. So the general concept of school accommodations, from the get-go was don't go over your symptom threshold, right? So if you kind of understand that, at some point your symptoms get worse, just don't go over that. And that this would allow the brain to continue to heal without prolonging symptoms. You wouldn't aggravate symptoms. But you could still have the students at school and they would keep them stimulated cognitively and, avoid a situation where they sit at home in the dark and get depressed, right? So this was all good, except we started hearing from the schools, we don't understand what that means. Don't go over your symptom threshold. And a lot of the patients also didn't really have enough insight with their symptoms to know, should I do this or should I not do this? I think I can do this test. I don't know. Oh, I did the test and later that day I had a terrible headache, et cetera, and I performed poorly. So these are all the factors that started to come into play as we started to break down guidelines for teachers and exactly how return to learn should look. It's at the end of the day, very individualized thing. So you got to take each patient, look at their symptom burden, look at their cognitive deficits, look at their visual issues, and put together a plan for them. And that's what the ICAP is. But this is generic accommodations per zone that are commonly used. We have a handout here that you guys all certainly have access to on our website that is nice, quick and dirty. If a lot of times when I'm talking to the ER docs, I'm telling them, hey, if you could just hand the patient this, circle one of the zones, it's something, and then from there, sort of we can figure out the rest. So even if you don't have time to really break down what's going on with the patient, this is still very useful right off the bat for athletic trainers, for nurses, et cetera. And this is what some of the accommodations methods might look like, right? So they can't test, but you can postpone the test, or maybe use an alternative method to test, right? They can't do PE, but they can do active rehab. The busy hallways in the schools just kill them, right? So we don't need to keep them home though. Let's give them a hall pass, and they can leave 5 minutes early when it's quiet. So there's ways to work all this out so that you can create the best scenario for the kid. And it's not easy for the schools. So you gotta really commend all the districts and the schools that have gone through the effort, and the teachers and everybody involved to put this stuff together, because it's not easy. And that's why 5, 6, 7 years ago, schools will say, well, we don't know what to do with all that. We don't have the infrastructure to do any of that stuff. But now they do, and it just makes the scenario much, much better for being able to implement return to learn. You got to have leverage points with return to learn. It's really critical. So if you don't, then you can run into problems, especially with complex concussions, right? Most of these kids, they're good kids. They want to get better. They want to get back to their sport. They want to get back to their school. They want to get back to their grades. But it doesn't mean that there isn't going to be that one that doesn't take advantage of the situation, right? And so if you need accommodations, then you're not going to be playing in your contact sport. You're not going to be doing video games. So there's a lot of different leverage points that we utilize, obviously depending on where they are along the return to learn stage. So I kind of touched on evoked potentials earlier. So this is, again, a very objective measure of cognitive capacity. We utilize this only in complex patients, so it's not really a tool for acute concussions. But in complex patients, it can tell you about the neurophysiology of the brain relatively quickly. This test only takes about 20 minutes or so to run. And it gives us a sense of their cognitive resources and cognitive capacity. So if cognitive fatigue is a big issue, we end up seeing pretty flat P300s like we're seeing here. I'll show you normal looking ones as we wrap up the case shortly. And this has been, P300s have been researched in neurodegenerative diseases for many, many years. But recent research is really looking at this in concussions, particularly complex concussions, and illustrating a very useful clinical utility in some of these complex cases. So this was another abstract that we had at PRISM, which is Pediatric Research in Sports Medicine, looking at P300 evoked potentials in our PPCS population, so PEDS complex concussion population, and we compared it to baseline age-matched norms that we had. So, and what we found is that the P300s and the PPCS group were significantly lower or suppressed compared to the baseline group, and coherence, which is a marker of interconnectivity and brain healing, was elevated in that group as well. So two markers that we saw neurophysiologically that were statistically significant that we presented on. So, okay, what about vestibular dysfunction? So this one's a little bit more straightforward, right? Vestibular rehab, right? That's the key. This is usually done by PTs. Many of our athletic trainers know a lot of these exercises and can implement this right away. And a lot of these athletes can make a big difference. But exercise is key too. So again, the exertional rehab protocol is going to be critical to help these guys improve their vestibular dysfunction. If they're too wobbly to be walking, then you put them on a recumbent bike or a sit-up bike. Sometimes the vestibular dysfunction is peripheral, like a BPPV, right? Where they have a otolith dislodge. That's only about 2 to 4% of these cases, meaning 95% or so are going to be central vestibular, right? But when you have someone in that 2 to 4%, you don't want to miss it, because you can do a simple repositioning maneuver called the Epley maneuver. And depending on which canal it is, maybe one of the other ones, and help these guys get better pretty quickly. So it's important to rule out, and you can use a Dix-Hallpike maneuver to rule out that they don't have peripheral dysfunction. The other thing on history with this is these are the folks that get the vertigo attacks, okay? So instead of dizzy, they'll tell you, I was fine, I did something with my head, and the room just spun like this, and I had to literally hold on to something. Those are vertigo attacks, and that's usually telling you it's BPPV, and potentially a canal repositioning maneuver can really help help them, or maybe even completely resolve it. If cochlear dysfunction, which a lot of times goes with bad vestibular injuries, remember those two, the inner ear houses both the cochlea and the vestibular system. We often will utilize ENT. We need audiology, vestibular audiology as well. And then not that commonly, but sometimes in the chronic cases, we'll consider medications. Meclizine is just an over-the-counter antihistamine that can be helpful in some of these patients, especially if they got to travel and stuff like that, because the motion sickness can really become a problem when they have a lot of vestibular going on. We use a number of tests, starting with the BEST, which many of you guys probably heard or do, part of the SCAT-5, the Balanced Error Scoring System. We have the luxury of having a force plate, Bertec force plate that gives us sway velocities and has multiple different protocols. So we look at that. Peripheral vestibular testing, I just mentioned the Dix-Hallpike maneuver to rule out any kind of peripheral vestibular problem. Dual tasking can be really helpful. So while you're having them do the tandem walk or whatever, give them some cognitive tasks and see how much that dual task is tolerated or not tolerated, and that can be helpful in terms of figuring out how bad their problems are and figuring out how to proceed with their rehab. And then these are some more advanced tests that really vestibular centers can do, but probably outside the scope of this talk. So what about visual dysfunction? So vision's a great one, and I think it's one that up until I want to say a few years ago, definitely got missed a lot, definitely neglected, because people think of vision as whether you can see or not see, right? My eyes are 20/20, my vision's fine, right? But visual dysfunction with concussion is not about acuity. It's about how your brain controls eye movements. It's about dynamic vision, right? Vision function. So really it starts with identifying it, characterizing it, and then after that you can start to treat it. So the problems are oculomotor movements and sometimes visual processing. These are the folks that the busy environments just throw them off, right? They can't be in a grocery store, right? Because they can't, their peripheral central integration is really messed up, and that's more of a visual processing problem. But oculomotor, we see this right off the bat, right? In many, many patients. That's why the near point convergence is abnormal, et cetera. But in some of the complex patients, it just persists and maybe even gets worse. And that's something we need to address. There's a variety of different tests we can use, simple and complex tests for vision. And I think all of you guys in here, some of the simple ones like NPC and King Divot and stuff like that, it would be a great tool to have in your toolbox if you guys take care of patients, on the sidelines or, wherever. So, and the complex ones, that's fine. You can refer for those. Now, here's another key point. So vision is a central profile. And what I mean by that is it's a predictor of academic tolerance, exercise tolerance, and prolonged symptoms. So vision can tell you a whole lot. And the reason for that is, you think about our daily lives, or these kids' daily lives, 80% of it involves vision, right? Whether it's activity, whether it's school, whether it's the screen, their iPhone, whatever, right? So it's pretty key. And so we don't want to be missing out on vision, because then that's when you're wondering why someone's not getting better. But if you haven't looked at this profile, this is often a problem player. So let's talk about that. These are a couple of the studies we looked at. So this is near point convergence, predicting return to learn. We looked at this a few years back. Basically, a simple abstract that we put together. And just look right here, the near point convergence, where it says NPC, for those of you guys on Zoom. When the NPC was really high, on average 15 or more, these folks were in the orange zone, okay? They were barely tolerating half-time school. As the NPC got better, and as it normalized, which is really considered under 8 centimeters, 6 to 8 is sort of the upper limits, then they're in the green and blue zones, which means they're full-time, basically doing everything or transitioning back to normal. So this is one example, and there's a lot on the research here, but where NPC, a simple vision marker, can be a nice predictor of academic tolerance or intolerance. We saw the same pattern with exercise, right? So when the near point convergence was really high, people are sitting there at 16, 20 centimeters, they generally struggled with getting up there to step 4 and 5. They were more in the step 1 and 2 range, which is just light to moderate exercise. They could still exercise, and we certainly initiated the active rehab protocol. But we could tell from their elevated NPC or their abnormal VOMs, they're probably not step 4, step 5 players. They're probably not going to be going maximal already, or certainly doing multidirectional. And that's the pattern we saw. By the time people were tolerating multidirectional, they basically have more or less normalized their NPC. And then here is another one where we looked at NPC and King Divot early on as being predictors of developing PCS or prolonged symptoms. So you can see higher scores with KDs and NPC being predictors of those that are more likely to develop prolonged symptoms. Okay, so some of the tests. So we got static tests and dynamic tests, right? So when we talk about visual testing, when we first see the patient, we do want to make sure that their visual acuity is okay. So we check, we do a Snelling, we make sure they're 20/20 corrected, right? We want to make sure retinal health looks okay. Got to look in the back of their eye, visual fields are okay. But ultimately, this is where the money is, right? The dynamic. This is where the abnormalities are. Near-point convergence, accommodation, which is looking at monocular vergence, looking at cover-on-cover tests to see how well the eyes are teaming, the VOMs, the King Divot, right? VOMs has isolated oculomotor and integrative vestibular within it, so it's a great screen. King Divot is a saccadic eye movement test. Also looking at their body, right? Do they sit there and they kind of tilt their head and their body, because vision can do that to you, right? It can make you develop a compensatory head tilt. So that's important to look at. We have oculomotor trackers to help us quantify and qualify their eye movement deficits, and ultimately more sophisticated tools like visual evoked potentials, which tell us about visual processing and can be helpful when you think they need prism glasses. So what's the treatment look like? Vestibular rehab is, again, a great place to start with our PTs, our ATs, work functional vision. And remember, functional vision is an integrated process. So even if you're starting with some pencil push-ups and some saccades and this and that, ultimately, these guys got to start to integrate that with balance and with cognition. Because if they don't, that's not real life, right? So you can start simple if they're struggling, but you got to try to move towards an integrated approach with vision, right? Reducing visual loads, this is big. And so sometimes this is the problem, right? You can do the rehab and you're like, why aren't they getting better? And then you find out they're sitting on their iPhone 6 hours a day, And so, that's like running on a torn hamstring, right? It's not, that's what I tell my team is, you don't want to get better, stay on your iPhone, I'll see you in 2 weeks. So it's really big to just hammer that home. And I don't know how many times I've had these teenagers come back, and then finally, maybe the third visit, the point gets across, maybe gets across to the parents, the phone gets taken away, and all of a sudden, things are a lot better, the next time I see them. So I think that's key. And if we do those two things, most of these guys get better. Okay, there are some that end up needing vision therapy focused rehab. OTs can do this, vision therapists can do this. And then the more severe ones that are not responding to those treatments, assuming you did them right, sometimes we'll need that neurooptometric evaluation like Dr. Pollock does for us. And so these are cases that sometimes need orthoptics or prisms. And that's just, you can think of that as like a brace, right? You got an unstable knee, you got to get a brace on there for a little while. And then once you start moving well again, then you can get the brace off. So this was a study very recently that my team was sharing amongst each other. Basically what they did here is they took 100 and so kids, I think 120 kids or so, half of them were 48 hours, no iPhone, the other half do whatever you do, okay? And what they found was a significantly improved time to recovery in the folks that the iPhone was taken away the first 48 hours. More than twice. Yeah, I think it was 8 days versus 3 days. And this was an acute concussion. But that's a very significant difference, right? So bottom line, this is not the time to be an iPhone junkie. So we got to really get that point across, okay? We're getting there. Cervical dysfunction. So most of the time, these guys are going to have suboccipital, so that's high up, paraspinal, trapezius. Pain and stiffness is the way they describe it, and they're limited with range of motion because they've been in a bad pattern, especially if they haven't had rehab, of tightening up even more, and they get stiffer and stiffer. So sometimes I see these guys at 3 months, they look worse than they did at 1 month. And it's because they have these chronic muscle spasms, sometimes with trigger points. And then other times with radiculopathy. So radiculopathy is when they may have a disc or a muscle spasm pinching a nerve that goes down their arm. And the Sperling test is one way to assess that. So a number of other tests that we do for cervicogenic. We want to rule out C-spine injury. And so if we're worried about C-spine injury, Sperling test is positive. We think it's from a disc pinching a nerve, et cetera, et cetera. We want to look at the spine. We get an MRI. Otherwise, if it's looking like the 95% or so of the cases, which are going to be more mechanical or musculoskeletal dysfunction that we see, then, and that's by far the most common, then we do some of these provocative tests to see what the results are. Ultimately, they'll have usually are going to have abnormal cervical range of motion, and then they'll have positive cervical provocation tests, as well as potentially positive trigger points. And then we move forward with treatment. So cervical rehab at the top of the list. I mean, that's why these guys want to get started early with this, even if they have a little bit of cervical, because it can compound and become a lot worse. Down the road, if we need trigger point injections, dry needling, acupuncture, these other things, we can do it. But from the get-go, cervical rehab is the key. And then understanding, is this a primary problem or a secondary problem? So again, you know, if they've got a bad visual issue and they live with a hip tilt, then they're probably going to have chronic muscle problems in their neck until you deal with the vision, right? So you want to be thinking about it that way as well. All right, migraine. So post-traumatic migraine or post-traumatic headache, extremely common, whether you want to talk about the acute or those with prolonged symptoms. You know, we generally start with the basics here: trigger avoidance, exercise, sleep. Sleep and migraine go together just, you know, very, 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 I mean, they're just so intertwined. So if their sleep's off, it's like, yeah, you're going to have migraines. So we need to address those things. If they have occipital neuralgia or these cervicogenic headaches, we want to treat that, right? So treat these underlying causes or triggers, particularly in a patient who doesn't like have a previous history of migraine or been on migraine meds, because you should be able to get them treated without having to go back on meds or putting them on new meds. So CBT can be helpful for migraine as well. And in some cases, we got to do medication. So I put a question mark there because we do all the above first. But if I've got a complex patient who's 3 months out and struggling with migraines and suffering, you know, we'll talk about all that, but it might be a scenario where we actually start something like amitriptyline, you know, every night to help them with sleep and migraine. So, and then there's some supplements as well that can be utilized. So, mood and anxiety. So, you know, exercise, again, there's a common theme, right? Coping strategies, sleep, psychotherapy and CBT can be used in these folks. And again, sometimes you need to do medication. So we try to start with the above, but if I've got a patient who's deeply depressed and that is the refractory profile and is not allowing them to do anything else well, whether it's rehab or getting better, then sometimes you got to deal with that, and getting them on a medication in a number of cases, at least anecdotally, I can say, has made the difference. Sort of got them out of the mud, and then they start moving, and then we get them off. Sleep, similar, you know, obviously exercise is very deeply tied to sleep. And if these guys were athletes previously or exercising, and all of a sudden they're not, and you guys have all probably experienced that, you know, that's not going to be good for your sleep. So the active rehab protocol becomes critical for this. We all know what sleep hygiene is. I think how we approach it and how we talk to patients, you know, is important. I try not to sit there and go through the 100 things. You know, I have a handout for that. I try to give them 3 things based on what they're telling me that I think are going to be key for them, right? So that their sleep routine is better. And, you know, those things could be anything from, one of the things I highlight a lot is the golden hour. The hour before you go to bed is the golden hour, no screens. So that alone can go a long way, right? And then, you know, may talk about a few other things as far as that goes. So, and then, you know, we do actually utilize melatonin pretty frequently if they're really struggling with sleep induction. There's other medications too. Sleep is one of those ones that I try to jump on top of. You know, I'm not a big medicine or supplement person, but I'm more liberal using it if there's true problems that I don't feel like is going to just be solved by some sleep hygiene. You know, the kid that's sleeping 3-4 hours, little sleep hygiene is probably not going to get them all the way there. They need that, but they probably need more than that. Okay. And then you can, you know, once you've normalized sleep, then you're on your way. So, all right. So back to putting it all together, right? So this is the approach. We want to look at all these different profiles. We want to think about treatments, targeted in each area, what's predominant, what's maybe the refractory profile. These are all important concepts. And what's the common thread highlighted in red that's in many of these boxes, treatment boxes? Exercise, right? The active rehab protocol. So it's very key. Back to this case. So this is our guy, if you remember, 3 months out, severe ongoing cognitive, vestibular, visual, exercise intolerance, cervical, migraines. What do we do, right? I'll just show you a couple of these tests because not everyone knows what these are. This is the King Divot test. You got to read these numbers left to right as quickly as you can, accurately, and it's timed. And someone his age, about 15 seconds per card is what you expect. So he's scoring 25, 31, couldn't do the third one, right? So he's demonstration card and then 1, 2, 3. Near point convergence was 17 centimeters. Normal is 6 to 8 centimeters. Accommodation was also long with some asymmetry that might suggest there's some unteaming going on as well. Vestibular testing. So his best testing obviously did not look great. Had to defer the third position. And then here's the force plate data, right? So the red is him, the gray is normative data. And what the red means is that his sway velocities are well beyond the normative data, so significantly abnormal. This is his oculomotor tracking test, starting with fixation, which he's just looking at a dot, looked pretty good. Didn't have excessive microsaccades. But once we start moving them, horizontal saccades, probably everyone in the room can look at this and say, it looks kind of messy. So the dotted line is the target, and the blue and the red represent the left and right eye. You can see not teaming well, just not hitting his saccades cleanly at all. And then here's smooth pursuits. Dotted line is the target. So these are smooth pursuits that don't look very smooth. And this is, in some cases when it's bad enough, you'll see the choppiness on exam, but sometimes you won't, because these trackers are pretty sensitive. So his cognitive testing, you can see here, processing speed and reaction time, 2 areas that are well below the first percentile. He didn't have a baseline, but when we see those kinds of scores in a kid that otherwise, and in this case was a 4.0 student, that's not normal. We know that, right? So we got to figure out what's going on there and help him on that front. His evoked potentials. So I'll just highlight right here where it says 1.7. The reference range for the P300 in his age group is 10 to 20 microvolts. So he's basically not firing very well, not to mention his performance tests also look terrible. So, so there's that. So this is what his patterns look like. So if we look at the central parietal, which is in blue here, the red line represents the P300 evoked potential. So this is an auditory oddball. They listen for a sound, beep, beep, boop. When the oddball happens, the brain automatically responds with a cognitive task, right? You had to discern the difference. And so it fires. And this is what it should look like, okay? You should have these nice, clean spikes right at the 300 millisecond time frame, which is the dotted line, telling you that that brain was responding appropriately, neurophysiologically speaking, to the cognitive task. When it's not, it looks like that. Okay, and again, normal would look like that. So what did we do for this kid? So we started with school accommodations because remember, he didn't have any. And we actually put a referral in. He's 3 months out with still pretty severe cognitive problems, put a referral in for neuropsych testing because we're anticipating he might need a 504 and just more help on the cognitive side. We got exertional rehab going right away and got him at least tolerating some dose of exercise and built on that week after week, okay? Physical therapy, and that was really to get formal vestibular, ocular, and cervical rehab going for him. We got occupational therapy for vision, ordered an MRI and got some labs of the pituitary to rule out spinal leak, MRI lesions, anything like that that's outside of the box. This clinical picture looked like complex concussion, and his MRI was normal, structurally speaking. Pituitary labs were also normal. So sometimes we do see, abnormalities with pituitary labs where, maybe their ACTH, which releases cortisol, is low, or maybe the thyroid release hormone is low, or gonadotropins are low. Those are all things that may be part of the concussion. And about 10 to 20% in complex concussions, we've seen that in the literature. So we want to evaluate that, rule that out, and those are treatable things. we work with the endocrinologist when there's a problem there, and we can treat those things. Cognitive behavioral therapy was implemented for mood and anxiety symptoms, which he had established, and is very, very common in those with complex concussions with prolonged symptoms for obvious reasons. And then medications really focused more on symptomatic relief for migraine, sleep, mood. So, okay, we made it. So conclusions. So in a nutshell, I would say this talk is about understanding that complex concussions, more or less, we're talking about persistent post-concussive symptoms that are lingering over a month. So once you have that scenario and they're not almost better, so a month of symptoms still struggling quite a bit, they should be referred to work with a concussion specialist at a concussion center so that we can really implement the treatments they need. Investigating predominant profiles is part of the workup here, so we can subtype the PPCS. We want to individualize and target treatments, and those treatments are going to be multidisciplinary, and we have multidisciplinary treatments for all different profiles. So we just got to really understand what are their predominant profiles and really try to target them. These profiles are interconnected and they influence each other, as I said. So if the profile of resistance is sleep, and you're not treating that, and sleep is causing cognitive problems and mood problems and other problems, but you're trying to treat those other things, but you're not addressing sleep, then they're not going to get better, right? So it's really important to think about the profiles that way and how they're interconnected, and what is the predominant or what is the refractory, because that's what you're going to go after, and those could be the key in terms of recovery. You can't do everything at once, right? It's hard to do everything at once, so you got to really hone in on where you start, and then eventually what the treatment path needs to look like. And I think that's it. So I'll leave you guys with this cool quote from Osler, and just field any questions here. How did I do on time? I have no idea. What time is it, guys? Okay, good. So yeah, I told you guys, till 7:30. So I will field a few questions for a few minutes, and then let everybody go home. Yeah. Yeah. Yeah, that's a great question. So for the Zoom folks, in case I didn't hear that, the question was, at what cognitive recovery zone, what color zone would we consider driving? Because a lot of teenagers drive. So, obviously, depending on their symptoms, driving may have been taken away, at some point or from the get-go. So, what I would say with driving is, if I was going to give you a color zone, probably be yellow. Okay, yellow and up, very unlikely in orange, and maybe not in yellow, right? So it still becomes, you can't really just use that to determine the driving piece. It still becomes a very case-by-case thing, especially for driving, because of obviously what's at stake. So you have to look at cognition, you got to look at visual, you got to look at cervical, and you got to look at reaction time, and all of those have to look pretty good. Otherwise, it's not safe, so regardless of whether they're in the yellow zone or whatever. So generally speaking, though, folks in the yellow zone, those things are looking pretty good. But you got to always look at driving, I think, individually. So, because you don't want to, yeah. Great question. Yeah. Yeah, it's a great question. Using speech therapy for cognitive rehab, and the answer is absolutely. So when we think about cognitive recovery on its own, we often think of speech, and that's sort of initiated because a lot of the folks with cognitive problems had issues, just like our case, with expressive language and aphasia, et cetera. So a lot of patients don't get it. They're like, speech? Why are you saying me speech? I got cognitive problems. So you have to explain that to them sometimes. But the speech therapist, that's exactly what they do. And they work with memory problems, not just expressive language. They work with all the cognition. So it's a great place for that. Occupational therapists are kind of unique in that they can hit cognitive and visual. You got to have the right one. It's got to be a neuro OT that understands TBI and so on and so forth. And they're also very good with dealing with people's worlds. whether it's school or work, right? Because occupational therapists, I mean, that's their thing. So they definitely have a role in terms of that. But if you're just talking, I got a lot of cognitive problems and I want to hone in there, yeah, speech therapist could be great and could be the best choice, really. So yeah, great question. Other questions from the crowd here, and then we can see if there's any chat questions, if there isn't any other ones here. Yes.
So we work in the health office at a school.
Cool. What school?
We're at Coronado. And
Okay, awesome. Yeah.
So I'm just wondering, you're going through the static and dynamic eye vision testing.
Yeah.
How soon will we be seeing any of that? Like, how would we be able to implement and actually notice those? We get kids that come in, oh, this happened yesterday. It's all practice.
Right. So the question is, how soon can we implement the eye testing, both static and dynamic functional eye testing? And the answer is right away. So, you know, it's a great test to do. I mean, these athletic trainers know it right there on the field. You know, they get hit, they come out, you know, I'm fine. You know, you start assessing their eye movements. The VOMS, you know, captures much of the dynamic or functional visual exam, integration with vestibular as well. So yeah, right away, and it can be a great marker, not just for sport and return to play, but for the classroom. So, you know, you've got a kid who says, I'm fine, but their eye movements don't look right. Their smooth pursuits are choppy, their convergence is out at, you know, whatever, 16 centimeters. They do saccades for you, and they're bouncing across, and they're saying it's giving them a headache. Those are, or making them dizzy. Those are all signs that visually they're struggling, and they're going to struggle in the classroom, probably with reading and those kinds of things as well. So, and like I said, when we see patients, we always want to rule out that, you know, there's no static problems. So we'll do like a Snellen and all that. It's very rare though. Concussion doesn't usually affect acuity. It affects functional vision. So usually acuity looks fine. When people tell you they're seeing blurry vision intermittently, it's because their eye teaming is the problem. You know, they're trying to track and their eyes aren't working well together, and then they think it's their acuity, but it's really usually not. Yeah. Great question. I think Kristen, you might have had one more.
Well, it was just along the lines of vision, and just, you know, I see that being an issue a lot, and seems to be more of a lingering aspect, and then of course is in conjunction with cervicogenic headaches and all of the postural things. But I know at one time there was an idea, a thought that, you know, maybe we would have more people refer people to for that vision correction, and, you know, whether it's short term or long term, that their needs are. Has that expanded beyond Dr. Pollack at all, or where are we at?
Yeah, that's a great question. In a nutshell, the question was, you know, if folks are having prolonged vision issues, where can we send them? You know, what kind of referrals can we do to help them? So, and has that expanded compared to, you know, 3 years ago or whenever we talked last? But so the answer is, yeah, it has expanded, but I think a lot of the ways it's expanded is within physical therapists' realms, within occupational therapists' realms. Even you athletic trainers, you know, have learned a lot more about it, right? So, and in a nutshell, you know, vision, when you have functional visual deficits, the place to start is going to be rehabbing, right? And then cutting down visual loads. And like most therapists can manage that. I think where you end up needing someone like a neurooptometrist, like Dr. Pollack, you know, who we have the luxury to be able to have her here, is when someone's doing those things, and despite all that, a month or two in, they're still not moving, right? It becomes basically a refractory profile, right? And that's a scenario where you go, okay, there's more going on here. And that happens sometimes, right? But I think if you can jump on top of vision therapy exercises, whether it's with you PT, OT, AT, whoever, be smart about visual loads, have return to learn and return to work accommodations that protect you from overloading visually. Most patients should be able to get there, you know? And a lot of the folks that don't, if you look at a common thread, it's because they didn't get any of that. You know, for 2-3 months, they hammered away. And what was problem became a much bigger problem, you know. And then now you're dealing with someone whose NPC is more than 30 centimeters, you know, that they're barely able to follow, you know, even get through the VOMs. And they have a lot of visual processing issues. The floors are moving on them. They can't handle being in a grocery store. At that point, you're putting it all together and saying, okay, this is someone that probably needs the neurooptometrist because they need more sophisticated rehab that's probably going to involve orthoptics and prism lenses. So, which is obviously, you know, you need them at that point to get those going. Yeah. Great question. Any other ones from the group here? And then we'll see if we can, anyone else here? Okay. Do you have a couple of chat ones or no? Okay, good. Well, unless there's any other questions, we're 7:30 on the dot. Thank you guys all for being here. Please take some pizza home. We've got some left over, and great to see all your faces. Thank you. Hey, Becky, I just want to introduce you to